All right. Good morning, everybody, and welcome. Thanks for joining us this week. So we'll get rolling here for the sake of time. So today we've got two presenters. We got co-fellows presenting today. We've got Jordan Orr and Andre Abadin from Swedish out in Seattle. They have clearly excellent ultrasound training out there, and with those folks, and they're going to be giving us a talk on subscapularis tendon pathology. So we will let you guys take it over and get going.
Okay, can everyone see our screen?
Yeah, that looks perfect.
Okay. All right. Thank you, Dr. Cruz. Yeah, so today we'll be going over subscapularis pathology. And first we'll start with all right. So we have our outline here. So we'll go over a case presentation. Then we'll go over the ultrasound protocol, followed by relative anatomy associated with this case. We'll go over some ultrasound images and the reports. And then we'll talk about the outcome of the case and just kind of have a summary about what we discussed. So we have a 63-year-old female that presents with chronic right shoulder pain for about 8 months. She states that she has poor balance, and so she has fallen multiple times within that time frame. And her most recent fall was about 2 months ago. She locates the pain along the anterior aspect of her right shoulder, and any movement of her right arm causes pain, but specifically, especially when she lifts heavy objects or just any sort of objects away from her body. She had 2 palpation-guided steroid injections done by her family medicine physician, but she states that she got at most about 1 week of pain relief. On physical exam, she had full passive and active range of motion, but she had pain with any overhead movements. And she had tenderness to palpation over the greater and lesser tuberosity, and also over the bicep tendon. She had pain with all rotator cuff testing, so that includes empty can tests, Speed's test. She also had pain with Hawking impingement and O'Brien's test, so it was difficult to assess what is the source of her pathology or the source of her pain. So because of a non-specific physical exam, our differential was pretty broad. So they included here a supraspinatus tendinopathy with or without a tear, bicep tendinopathy, subscapularis tendinopathy with or without a tear, calcific tendinopathy of one or of multiple rotator cuff tendons, glenohumeral joint osteoarthritis, and humeral head fracture due to her history of multiple falls. So because of that history, we started with x-rays, and on the left is an AP view of the shoulder. And of note, there's no evidence of fracture, which was our concern when getting these x-rays. It did note that there is some sclerosing of the bone, which can kind of indicate that there is minor glenohumeral joint osteoarthritis. But overall, this looks like a pretty good shoulder x-ray. And on the right, this is the brachii view. And it clearly shows it's a view that has a great viewpoint of the glenohumeral joint, as you can see in the picture. And again, no evidence of fractures.
Okay, so we'll shift into kind of the ultrasound portion of our case. So this is the AMSSM scanning protocol. And we did a complete scan on this patient since, as Andre mentioned, her presentation and physical exam was pretty non-specific. But the parts of the exam that we're going to focus on today are mainly the biceps tendon long head, the subscapularis tendon, and then the dynamic examination for the biceps tendon, potentially subluxing or subcoracoid impingement. And so just kind of getting our patient set up for the actual ultrasound, We always use a linear transducer, and these are the range of transducers that we have in our clinic that we use frequently. We have the patient sit on a stool, and we have a few pictures coming up where you'll get to see that. When we have the patient seated on the stool, we kind of stand behind the patient, and we're easily able to label our images as well as compare side to side, as opposed to if you have them laying down on the table, it's a little bit more difficult to have them roll from side to side to look at both shoulders. Obviously, if anyone has any other suggestions, we're open to hear that at the end. But basically, we like this style for ergonomics, patient comfortability, as well as the ease of mobility for positioning. Okay, so we'll start with a little bit of anatomy review. So we're going to mainly focus on the biceps long head scan. The biceps long head starts at the supraglenoid tubercle of the scapula and goes and inserts onto the radial tuberosity. Other pertinent anterior shoulder things that you could also scan are the muscles that come off of the coracoid process. I don't know if people can see my arrow, but things that are coming off this coracoid process include the pectoralis minor, the coracobrachialis, as well as the short head of the biceps. And then the layer that's cut away in this picture would be the deltoid, the pec major, and a little bit of the platysma. And then so the subscapularis is the other structure that we're really focusing on in our ultrasound scan today. It comes from the subscapular fossa on the scapula, and it inserts onto the lesser tubercle of the humerus. And this tendon insertion in the picture you can't exactly see, but in this diagram, I think it represents it very well. This was a paper done by Dugas et al., and it shows that the insertion of the subscapularis is broader, more superiorly, or more cranial at that aspect of the tendon, and then it's more narrow on the insertion, more caudally and laterally. So the insertion at that lateral and caudal aspect is almost a muscular insertion. And this picture is depicting the plotting of the area around the tendon. So broader at the top and more narrow at the bottom. And they also threw out some numbers of the footprint itself. So the length of the insertion from superior to inferior aspect is on average 2.43 centimeters. And then the width of the insertion on average from medial to lateral is 1.79 centimeters. So these are kind of our normal scans. We'll get into our case in a little bit. So we have the patient positioned on the stool, like I mentioned, palm up, they're palm supinated. And we start with the biceps tendon short axis as our home base. And we really try and wag our tail of our transducer to get that biceps tendon nice and hyperechoic in that bicipital groove. So the green check mark is obviously the optimal image, and the red X would be an image that's affected by anisotropy. That tendon is hypoechoic. You can mistake it as like a tear or as a completely different structure, as opposed to when it's not a nice hyperechoic structure with a green arrow. And we start at the cranial-most aspect of the tendon at the rotator interval, and we scan all the way down to where the tendon dives under that pectoralis major tendon, and that's what this bottom picture is showing. And then we switch into long axis. So when you're scanning long axis on the biceps tendon, you really want to make sure that you heel in as you scan distally to really flatten that tendon across the screen and get that nice fibular appearance. This bottom right picture is showing the lesser tubercle. So when you're scanning more medially, you'll run into that. And so, you know, that's the most medial aspect of that biceps tendon or bicipital groove. And then so you know that you need to scan back laterally to get over the tendon. And I should mention these pictures on these slides are from Dr. Jacobson's book. And so moving into the subscapularis tendon long axis, you really want to make sure you bring the patient into external rotation. Sometimes we hold the patient's arm or we set a pillow on the patient's lap if they have some difficulty holding their arm there for an extended period of time. We're usually pretty swift with our scans, but just to make sure they're nice and comfortable. So the red X is, that picture is depicting internal rotation or just keeping the arm at that location where you were scanning the biceps tendon initially. And the green check mark is bringing it out into external rotation. And one reference that I was reading specifically mentioned, and this makes sense to us as well. If you're not externally rotating that tendon, you could potentially miss a myotendinous tear, because that aspect of the muscle and tendon is deep and more internally rotated from when you're actually scanning. So obviously anisotropy is a big key, but you also don't just want to miss tendon pathology in general from positioning. And then we move into short axis. The main thing to know about the subscapularis tendon and short axis, the subscap is a multi-pinnate muscle. So there's multiple tendon slips that are apparent specifically in the short axis view, and you don't want to mistake those for tendon tears because they appear hypoechoic, and you can see they're not as apparent in this kind of middle picture, but then in the bottom right, you can really see those hypoechoic lines, and those are the tendon slips. And you want to be sure not to mistake those for tears, because other muscles are not multi-pinnate. So this would probably look like a tear in a non-multi-pinnate muscle. And then, so this is our dynamic scan for biceps subluxation and or subcoracoid impingement. So I'll go ahead and start this. So the goal of this scan is to really try and keep that biceps tendon and coracoid in view at the same time, and obviously try and get that tendon to be nice and sharp and hyperechoic. And you're looking for that tendon to move outside of the bicipital groove with that internal rotation, or you're also looking for pooling of the subcoracoid bursa, which would occur here, and it would be kind of like a black triangle or a black, almost like fluid collection that would appear there, and that would be indicative of the subcoracoid impingement.
So now we'll go to the ultrasound images of our case. So this is the bicep tendon in both short and long axis. So on the left is the short axis, and on the right is the long axis. And as you can see here, this is the bicep tendon within the bicipital groove, and it's nice and hyperechoic. No pathology associated in short axis. And in long axis here on the right, you can see a nice fibular pattern that runs across the screen. It's flattening out. And one thing to note is that there is a hypoechoic or anechoic area just superficial to the bicep tendon. And so this could represent possibly an effusion within the subacromial or subdeltoid bursa. And so these are still images of the subscapularis tendon in long axis. So here on the left, we can see that there's part of the tendon. You can see there's a nice fibular pattern. It's hyperechoic, like we see a normal healthy tendon. But as we move more medially, we can see that we start to lose that fibular pattern. The tendon starts to become heterogeneity, which is a mixture of hyperechogenicity and hyperechogenicity. And then you can also see this specific area of hypoechogenicity that could possibly represent a tear. And as we fan through the tendon, we can see this area of corticoid regularity. While it is normal to see some corticoid regularities within the subscapularis tendon insertion, this is more generous than what is considered normal. And so this is associated with pathology. And you can see there's a focal area of hypoechogenicity just superficial to that. Now, it's hard to call pathology just based on still images. So I really like to use a video to assess that. So as we go through this video, the goal of this video is me to try to prove to myself that this is a tear and not just due to anisotropy. So my focus is really on this hypoechoic area just above this cortical irregularity. And it could be quite tough to tell, but if you can appreciate this, the hypoechoic area doesn't really disappear as I get over this cortical irregularity. It stays pretty persistent despite my best attempts of trying to, quote, fill it in with tendon. So this is consistent with a partial tear of the subscapularis tendon in the long axis view. And I say partial tear because as I move more superficially along the bursa, I can see some tendon there. So I know that it's not going through the whole entire tendon and long axis. And then I also see focal areas of hyperechogenicity. So this can represent calcium deposition within the tendon. So now we go to short axis, and like Jordan mentioned, this is a multi-pennate structure. And as you can see here on the leftmost image, you can appreciate that. And as I move to the middle picture, I start to see long areas of hypoechogenicity. And in order to prove to myself that this is a tendon and a tear and not just normal anatomy of the tendon, I fan back and forth. And again, as we get over this cortical irregularity that you see on the rightmost picture, there's this focal area of hypoechogenicity. And again, still images are tough to appreciate that. So we'll go to a video. And as I fan through the tendon and short axis, I get over this cortical irregularity. And there's this focal area of hypoechogenicity that's pretty persistent and is consistent with the location of my previous video of the tendon in long axis. So again, this represents a partial tear within the subscapularis and short axis. And again, I say partial tear because I can see fibular architecture just superficial to that along the bursa. So this is a articular sided partial tear with cortical irregularities, as well as calcium deposition noted by these focal areas of hyperechogenicity.
So now we'll transition to the report that was put together from those scans. Like I mentioned earlier, a complete scan was done just because of her vague kind of exam and history, but we're going to mainly focus on the biceps tendon and subscap, the anterior shoulder pain, as the main location of her symptoms. But this is kind of what our full ultrasound report looks like. We outline what we have scanned. It's templated, but we can add things or take them away, obviously, if we did not do them. And then we go into our findings where we really try to describe what we're seeing. And as a fellow, I've noticed that sometimes I'm like, I don't actually know if that's a calcification or a retracted tendon that's looking hyperechoic, or what is that fluid? So it's really been really beneficial for me just to step back and try to describe it. Is it hypoechoic? Is it hyperechoic? Where is it located in the tendon? Like Andre was saying, bursal sided versus articular sided, anterior, posterior. Just really kind of using our words as best as possible to describe things if you're not exactly sure what you're seeing, and then correlate those a little bit more with your physical exam and the impression potentially. So there's a lot of words on this slide, so we'll just move on to the next one, which is really focused on what we looked at. So the biceps tendon, and I guess I could have put the subdeltoid subacromial bursa on here, because we were able to see that in the views that Andre mentioned. There's a little thickening there, but overall the biceps tendon was normal in appearance. The subscapularis, the description that we used, I'm just going to read it off the slide. There's a cortical irregularity within the mid portion of the footprint of the subscapularis, with associated hypoechogenicity and interspersed hyperechoic material consistent with a partial thickness, partial width tear of the subscapularis with calcific formation within the tendon. And then kind of our summary of that, which is a partial thickness, partial width tear of the subscap with associated calcific deposition. And so the treatment and outcome for this patient, I think if you can go back and look at our full report, she had a supraspinatus tendinopathy and tearing as well. So we offered her a nitroglycerin patch for pain relief just over that anterior shoulder. However, she did not tolerate that. So her main treatment was physical therapy with a plan to follow up with a corticosteroid injection if her pain was too much to complete PT, or if after many weeks of physical therapy, it wasn't improving. She improved without needing an injection, and she transitioned to a home exercise program at the 8-week mark, and is overall doing well. So in summary, things that we hope that you take away from our presentation today is that you really want to make sure the patient is in external rotation for scanning that subscapularis muscle and tendon. The subscap is a multi-pinnate muscle. The cortical irregularities that you can see medial to the insertion of the subscapularis or at the insertion can be normal. So really look at the tendon that's superficial to those cortical irregularities to see if there's abnormalities in the tendon, and check it in long and short axis to really convince yourself that those cortical irregularities correlate with a tendon pathology. The tendon insertion for the subscap is broad at the superior aspect and then narrows down at the distal and lateral most aspect. And then on the dynamic scan, pro tip is to keep that coracoid and biceps tendon in view. And I think that is it. We wanted to give a big thank you to all of our attendings who help us with ultrasound day in and day out, Doctors Henning, Lloyd, Erickson, Cahill, Vernice, and Dr. Porcho. And special thanks to Dr. Henning and Dr. Lloyd, because they do our Friday morning didactics. And actually we have time for a coffee break in between this morning's didactics, because we start at 6:30 a.m. And it's just about 6 a.m. here our time. So thank you to Dr. Cruz and AMSSM for giving us this opportunity. It was really fun to reflect on how much we've learned this year.
All right. Hey, great job, guys. And again, thank you. I know this is so hard for our West Coast folks. It's just so early. So thank you guys for getting up and giving this talk. I have just a couple quick points to make, but one question for you guys. You know, obviously you focused your presentation on the anterior shoulder and the subscap and the bicep, but for this patient, you did complete a full shoulder complete examination, correct?
Yes.
Okay. All right. Yeah, that was just one point I was going to make, is obviously, you know, we try to not just focus on the one area of pathology and make sure, you know, we fulfill the requirements for the complete examination. So, okay, that's helpful. So you made the point about the multi-pennate appearance of the subscap. I think that's important. I mean, it's similar to triceps tendon, has a similar appearance. I think early on, you know, when folks are learning to scan these regions, you will see, you know, these alternating regions of hypo and hyperechogenicity, which is due to that multi-pennate structure. And if you see that appearance in a different tendon, you know, that would probably be pathologic. It probably would be a tear, right? But that's something that we do see as normal in the subscap, particularly in short axis. So that's a good point to make, and a good thing to keep in mind as you're scanning this area. You know, you made this point also, trying to get the patient as far as you can out into external rotation. You know, similar idea behind getting a patient to, you know, modified Crass position. If you're imaging the supraspinatus, you need to pull tendon out from underneath, you know, whatever bony block there is, so supra underneath the acromion, and then the subscap out from underneath the coracoid, to really prove to yourself that you're evaluating, you know, the entire tendon. I've seen a couple times, and I've gotten burned early on, where, you know, people really don't like to get an external rotation, especially if their shoulder hurts. And, you know, I've had times where the distal insertion of the subscap looks okay, but the patient really doesn't want to externally rotate. And I'm like, well, what the heck? I don't know why they hurt so bad. And then, you know, you really get them out there and coax them to get out, and you see, you know, closer to a myotendinous tear. So something that's deeper underneath the coracoid. So that's an important point to make there. So, so well done with that. The other point, I think you mentioned looking at the subacromial bursa while you're looking at the biceps. You know, certainly you can see it in that area, and, you know, anybody who does the injection or procedures in this area, you know, subacromial bursa lives right on top of biceps tendon, right? And so oftentimes when you're injecting, you know, if you don't see that nice circumferential flow around biceps, you're probably in the bursa, in the subacromial bursa. But I would just say, you know, if you're going to scrutinize the subacromial bursa or bursal fluid or thickening, I'd probably do it when you're looking at the supraspinatus tendon. Is probably just a better area to visualize that. And then obviously the bursa over the subscap is going to be your subcoracoid bursa, right? So you can, like you mentioned, I think Jordan mentioned that, You can look for bursal fluid, and dynamic scanning can be really important here, also looking at subcoracoid impingement, so on and so forth. Yeah, I think that is all I have. I think Doug is on. He is.
Yeah. Thanks, Jordan, Andre. That was very good. And we haven't really had a chance in our case series to talk a lot about the subscap, and then it's an important part of the shoulder assessment. I'm also going to probably highlight a couple points Ryan made based on my experience. And the first is, both of you made the point about external rotation. When I get a patient with a frozen shoulder and we're doing a scan on, it's an incomplete evaluation of the subscap. And I think that's important to put in your report, due to the patient's inability to, externally rotate, there's incomplete evaluation of the subscap or non-diagnostic evaluation of the subscap. And so you should put that in there because, as you point out, you're not seeing the length of the tendon itself. Again, just to highlight, probably the most common abnormality I see when I put the probe on the subscap with rotator cuff disease is fluid in front of there. And actually, as Ryan mentioned, that's a subcoracoid bursa. So there was a great study that showed about 80 to 85% of the time, the subcoracoid bursa communicates with the subacromial subdeltoid bursa. And so if the patient's sitting up, that's essentially dependent fluid that has come into the subcoracoid bursa. And obviously it's a clue that now you got some rotator cuff disease going on. So that's probably the most common abnormality I see. When I see potential subscap pathology, I do two things that you do. I do two dynamic studies. One is externally and internally rotate. And in fact, I had a case of this yesterday where it was a full thickness subscap tear, but at first it looked okay. And that's because sometimes they get a little anterior capsular thickening. And so by internally, externally rotating them, you can now see the plane of the anterior capsule and realize that the next plane is the lesser tuberosity and not the subscap. And so that's the first dynamic study. The second dynamic study or video that I get is going from cephalad to caudad. And what I'm showing is I'm proving that I've now scanned the full width of the subscap tendon, because probably one of the most common pathologies of the subscap is partial thickness tearing of the cephalad fibers, which is a common pattern. You get some bicep tendinosis, and then oftentimes you start at the anterior supraspinatus and work posteriorly. So that's probably one of the most common patterns with rotator cuff disease. So the surgeons will see all the time. They'll look with the scope and they'll see the undersurface fibers of the subscap torn. Probably the last point I want to make is we forget that we can actually see the subscap muscle. And so if the patient is lying supine and they put their palm of their hand behind their head, and so they're abducted, internally rotated. So if you're just laying, yep, exactly. And you can actually see the whole muscle and myotendinous junction in the tendon itself in that position. It obviously with very painful shoulder, that's hard, but when we do scan in that position, for example, if we're looking at the teres major, lat dorsi complex, or the quadrilateral space, you can see the entirety of the subscap muscle and tendon. And sometimes we forget about that. So that's also something to put in your bag of tricks if you're seeing subscap disease. But otherwise, you guys hit all the highlights well. So nice job.
Thank you.
Thanks.
Yeah, I agree. Great job, guys. All right. Y'all can go get your coffee and tell Troy and company that we all said hello, and we will send him the YouTube link so he can watch this later. All right, thanks again. So we, as always, we are off next week, and then we're back on, holy cow, it's June. Back in June 3rd. Brian Studer at Mayo. He's given a talk on retrocalc bursopathy. And that will be it for today. Thanks again, guys. Have a good rest of your Friday and happy weekend almost.
Thank you.
Thanks.